Hello, everyone, and welcome to Modern Conception, a new era of fertility decoded. I am Brittney Sobel, the founder of Sloane.
And I'm Amanda Zurawski, co-founder of Sloane.
Today's episode is about a deeply personal and increasingly common issue, infertility. We're not going to be discussing biology, though. We'll discuss access, inequality, and how the rise in infertility is affecting public health in America. So we are very honored to have Dr. Chelsea Clinton as our guest today. Thank you for joining us. I'm going to introduce you, and you have quite an impressive introduction.
Please give the brief version. I'm just happy to be here with my friend Amanda and Brittney. It's so nice to also share space with you today.
Thank you. So Dr. Chelsea Clinton is an advocate, a storyteller, investor, mentor, teacher, and most importantly, mom to her 3 kids who we were just speaking about. As vice chair of the Clinton Foundation, Chelsea works alongside the foundation's leadership and partners to improve global health and wellness, increase opportunity for girls and women, create economic opportunity and growth, and inspire emerging leaders across the United States and around the world. A longtime public health advocate, Chelsea also serves as vice chair of the Clinton Health Access Initiative and uses her platform to increase awareness around issues such as vaccine hesitancy, childhood obesity, and health equity. In addition to her foundation work, Chelsea is the co-founder of Metadora Ventures. She teaches at Columbia University's Mailman School of Public Health and has written several books for young adults and readers, including the #1 New York Times bestselling, She Persisted. Chelsea holds a Bachelor of Arts from Stanford, a Master of Public Health from Columbia's Mailman School of Public Health, and both a Master of Philosophy and a Doctorate in International Relations from Oxford University. We're done for the day.
And that's time.
Way to make us feel awful. We are not worthy, really.
Stop. No, hardly.
No, Chelsea, it's truly a privilege to be here with you, so that everyone knows that she actually is human, and she is Superwoman, but she's also human. We want your coffee order.
Oh,
do you
my
drink
gosh.
coffee like us? I see you.
I drink a lot of coffee. I try to not drink too much coffee. I drink only black coffee, but I drink black coffee in a myriad of forms. I'll drink like an espresso. I'll drink a black hot coffee, a black iced coffee. I'll drink like day-old iced coffee if I remember to put it in my fridge the night before. I really love coffee. As Starbucks moved in between my high school and my ballet school my junior year, so I must have been like 16, and I started drinking coffee then, and I just have never really looked back.
Oh, that's dangerous. I have a Starbucks that's about 1.5 miles from my house, and so I tell myself that if I want the Starbucks, I have to walk there. So I am earning it. I'm justifying the cost with a walk.
It's a reward.
Yeah, exactly.
Okay. All right, we're going to jump right in. The first topic, we want to speak to you about fewer children, but why? So birth rates are declining, and the public narrative around it has been around personal choice. So personal choice to wait to have kids, personal choice to not have children. But the bigger issue is really the social and economic barriers. So can we unpack this?
Well, we can try. Where to begin? Birth rates are declining, around the world. So this is not just idiosyncratic to the United States, although certainly in some countries they're declining less, or they've declined and then they've stabilized, and that hasn't happened here. They've declined more, and they continue. Birth rates continue to decline here, and I think, Brittney, the reasons why are embedded in the framing of the question. That yes, there are now multiple surveys that say women, sometimes couples, families are waiting to have children. Now sometimes that very much I think feels and is a personal choice. Sometimes it's the result of wanting to have greater financial security. and stability, and that too is something that we see in survey data from around the world. We also, though, here in the United States, compared to other relatively wealthy countries, make it financially harder to have kids. It's often more expensive to have a child, more expensive to raise a child here in the United States for many reasons than it is in other wealthy countries. And some of those reasons relate to more expensive health care, so maternity care, prenatal care, postnatal care. Many countries have subsidized child care. We do not have that. Many countries have kind of universal, effective, like early childhood education starting kind of well before we do here with kindergarten. And so I think, Brittney, it is a result of many different factors. And I think we have to be candid that it is a global reality that most countries, not just many, but most, are facing. But we have particular challenges here related to policies that we have chosen to not enact or to not fund in the United States that we see other countries have enacted and have funded that have helped either ameliorate the decline in fertility rates or have really helped stabilize it in recent years.
It can be so frustrating, I think, for someone like myself that is desperate to have kids and you just want it to be easier. And instead, the policies that you're mentioning are making it harder and harder. And it just, can feel like such a barrier. And we know that 1 in 5 married women in the U.S. suffer with some form of infertility, myself included. And I think that it's not just a private experience. I have so many friends who are also dealing with infertility. I think it really, to your point, is a public health indicator. And so we have limited data, we have limited funding, very little public conversation around this topic. And I'm curious, why do you think this has been invisible for so long if it's a growing problem?
Well, I think, Amanda, thankfully, the way that you started that question, you being, courageously candid about your own experience and also, sharing that you have many friends who are also kind of, navigating through, hopefully ultimately successly, fertility challenges, I think signifies that something has shifted, right? I do think, 10 or 20 years ago, I don't know if those conversations would have been happening even in private settings, given all of the historic kind of claustrophobia there's been around anything that relates to women's health. I mean, how I think, going back even, when I was a teenager, I don't even know if my friends really talked about our periods, right? I think there was sort of this sense of like, this is just what's happening to you. Like, there's nothing to be ashamed of, but it's still very private. Like, it's not something that's to be shared or discussed. And I do think, thankfully, now there's this sense of course, it is intimate. And if you choose to keep it private, that is your choice. If you choose to share it, that also should be your choice. And there should be no iota of shame attached to whatever decision a woman would make about kind of what feels right to any of us to share about our bodies and about our health, inclusive, but not only as it relates, to our fertility journeys. So I think, thankfully, like, we're in a healthier place where there is less stigma, where there is more acceptance, where there's more hopefully healthy and not weird, like curiosity, and then kind of all the conversations that can be catalyzed kind of out of that. And I think simultaneously, it is also true that we still don't have enough data, that we still don't know enough about kind of women's health broadly to then know how to really ask specific questions, often for ourselves or to support our friends or our family as they're asking specific questions to hopefully make those fertility journeys less traumatic, less stressful, hopefully kind of more efficient in a real meaning of the word efficient. Space and place, for individuals and families alike.
Mm-hmm. I think it's so interesting and important what you said about the choice to share your journey, your situation, whether you want to or not, and with whom you do or do not want to share that with. I think Brittney and I talk a lot about community and how impactful that can be and how isolating infertility and fertility journeys can be. And so having a community and the option to talk about it is really opening up the conversation for others as well, which I think is important. I put a lot of faith in Gen Z because they seem to talk about their feelings and their emotions and their health to anyone and everyone on social media. So I hope that this is a conversation that we will continue to have and it will continue to grow because it's really helped me.
Well, I also think, Amanda, I think about how, I've had a few friends who, achingly, sadly, have had miscarriages, and how even in recent years, I feel like there's now, thankfully, a broader awareness of how painfully common it is for women, for families to experience miscarriages, how overwhelmingly it's not because of something that someone did. It's a genetically related tragic loss. And so I think, Amanda, there's just so much still around kind of what women experience in every part of life that we need to continue to create space to be able to talk about and to be willing to listen and just to continually be in that sense of creating community that you mentioned.
Yeah, I think that's right.
Yeah, community has meant so much to us and means so much to a lot of women, but for many, community only goes so far. They don't have access, and that's why we're creating it at Sloane to help bring access to good reproductive health care to those in need. But I want to speak about access for a bit. Particularly for women of color and minorities, they're in neighborhoods that probably don't have reproductive clinics, good health care, good insurance coverage, and there's a undeniable systemic bias in the medical field when it comes to reproductive health. What do you think needs to shift so that access to reproductive care is a right and not just a privilege?
Well, I think there's also, Brittney, the larger question just around, healthcare holistically, of which, of course, reproductive healthcare, must and should be, an essential part. Certainly, the recent passage of what I think of as the big awful bill is going to make it harder for many millions of Americans to access healthcare. There's been a lot of attention paid to the shifts around Medicaid and the kind of administrative burden that's now going to, reside on the shoulders of people who have the least time, most of whom are already working, an extraordinarily high number of hours to be able to provide for themselves and their families, and the challenge of having all the right documentation to prove that they're working those hours, volunteering those hours, in school for those hours is certainly onerous. And we know from my original home state of Arkansas that also tried a Medicaid work requirement, very hard to put into practice with real kind of integrity and verification and consistency. But one of the other parts of the big awful bill are all of the changes around how hospitals receive kind of payment from the government for services that they provide. And I won't get into all of the kind of details here, but the estimates of what these shifts will do to rural healthcare, range from somewhere to 300 hospitals will have to close because they won't be financially viable, up to twice as many. And so, I think it's not only that we're making it harder for working women, many of whom are already mothers or who hope to become mothers, plan to become mothers, because we're making it harder for them to have insurance. And again, It's not like Medicaid is a check in their pocket. Like this is not a government quote unquote giveaway. This is the government recognizing that we all have a vested interest, I would argue a moral one, but certainly a societal and an economic one to ensure that people are able to access healthcare kind of when they need it for themselves and their families. It's also, though, what will happen to women in rural America. Right now, again, thinking about my home state of Arkansas, more than a third of women in Arkansas already live more than 2 hours away from a clinic where they can receive OBGYN care.
Yeah.
If rural facilities close, in Arkansas, but also here in upstate New York, or really in any part of rural America, like the math just gets that much harder for everyone, but especially for working moms. Will they have the time, even if they have insurance coverage, to drive maybe now not 2 hours, but 4 or 5 hours to get a mammogram? Will they have time to drive to be able to get their pap smear? Will they have the ability to take time off to drive to even show up for a prenatal appointment? Women don't skip healthcare because we don't know that it's important. We either aren't able to access it because it's unaffordable or it's just infeasible in the logistical realities, of our already often like incredibly busy lives. And so it is painful that we know that expanding healthcare ensures that more people access the healthcare that they need, particularly preventive care, especially for women. And we know how many more women have gotten screened since the passing of the Affordable Care Act and the expansion of Medicaid. Like we know that expanding health insurance works to help make people healthier. We now are acting like we don't know that. And we're going to make it harder for rural women, regardless of race, ethnicity, age, like party affiliation, to access care. And I want the Republican women to have just as good a care as I want the Democratic and the unaffiliated women to have in our country. This shouldn't be a partisan issue.
Yep, that's exactly right. Everyone should be able to have access to whatever care they need. I mean, you and I talk about this all the time, and you hit on it a little bit, but I really want to dive a little bit deeper because we know that infertility doesn't exist in a vacuum. And the United States shamefully has one of the highest maternal mortality rates in the world. And in this post-Roe world that we're now living in, with all of these abortion bans, we're seeing it. We're seeing the real impacts on reproductive care, everything from miscarriages to IVF. And so tell us a little bit about what the long-term landscape looks like if we can't address this comprehensively now.
Well, Amanda, I think we see what the future looks like as we're living with it in the present, right? So we see the abortion bans, the completely draconian, non-evidence-based, non-kind of medically informed abortion bans that have been put in place across the country, and the very real harms that they're causing. I mean, to you certainly, and to many others, in your state of Texas, where we know that women have died because they were denied urgently medically necessary health care that happened to be abortion care, and doctors were worried that if that care was provided, they could lose their medical license and go to prison for 99 years, which is what the penalties are in Texas. We also know that doctors have similarly delayed care in Georgia. And again, women have died. Women have been left with kind of lifelong, like internal burdens of infertility and also of other organ damage. I mean, the bans have very real human costs in lives, in fertility, in health, in the ability to earn a livelihood, to be able to pick up other children that you may already have brought into this world. And so the harms of the bans are extensive. One of the challenges now is states are actively blocking both data collection and data reporting about the harms of the bans. And so we see this, again, most extremely the case in Texas and Georgia, but also see other data being obscured in other states. So, for example, like in Texas and Georgia, like they're just no longer collecting data around the health and well-being of pregnant women and new moms. Now, that's deeply worrying because there's many other things that sadly can be very real risks for pregnant and new moms that we do have a public health invested interest in knowing, whether we're thinking about postpartum depression and stress or preeclampsia, right? We have a public health imperative to know kind of the health and well-being of pregnant women and postpartum new moms, partly so that we can hopefully have better interventions to help ensure that everyone can have a healthy pregnancy, that every mother can deliver a baby safely and then continue to thrive postpartum, but also because historically in public health, we've always thought that maternal mortality and maternal well-being and infant mortality and infant well-being are bellwethers for how the system is doing broadly, right? If we are able to take care of people when they're at their most vulnerable, and pregnancy is incredibly vulnerable, childbirth is an incredibly vulnerable time. Being a newborn is, by definition, an incredibly vulnerable stage of life. If we're able to take care of people in these moments, hopefully that means that we're able to take care of a broader population and our society as a whole.
Yeah, I think the data piece is so alarming and critical to talk about. And I think, in states like my home state of Texas, they're even trying to make, not only are they not collecting the data, but they're trying to make it harder to access information. So even just to educate yourself and to advocate for yourself is becoming more and more difficult, which is part of why we're so excited to bring people It Is Sloane, because it will help them not only access information, but real access to physicians that can help them on their fertility journey. So, okay, let's see if we can turn this around, because it can sound pretty bleak, right, when we talk about some of this stuff. Like I said, we're excited to bring It Is Sloane to patients. And we have some tangible tips for our listeners on what they can do to advocate for themselves. I know we've learned how to advocate for ourselves in our journeys. What's one, Brittney, that you've learned or that you would give to listeners?
I would say to connect with a trusted reproductive endocrinologist. There are very few of them. There are only around 2,500 reproductive endocrinologists in the country. And out of those 2,500, something like 1,500 are in active practice. So I would find a good reproductive endocrinologist who you trust and can confide in and seek treatment with, and a good lab with good testing and embryology department and such. It's a good starting point.
Yeah, definitely. And I think one thing I was surprised to learn is that a lot of employers' healthcare will cover different aspects of fertility. And so I think understanding what's covered and what's not is really important.
And asking
what's your tip?
Well, asking for benefits that may be covered at places where your friends or family work. Mm-hmm. I think particularly if you're working for a mid or large size company where there really are professional benefits managers and people to have this conversation with. Because if there's something that you think would have real relevance to your health and your well-being, you're probably not alone, right? It's probably a benefit that other people in your company could quite literally then benefit from. And I would say too, President Trump made a big deal about covering IVF as a kind of mandated part of, he may not have ever had sort of the specifics, but at least the expectation, I think, was through kind of what the Affordable Care Act infrastructure requires, even kind of what the federal government, would require Medicaid to do. He recently, backed away from that, and the White House said they did not have an intention to follow through. I'm not terribly surprised by that, but I'm a big believer of trying to hold people to kind of what they've said. And so I would also just say, we're citizens not only on an election day, but every day. Mm-hmm. And the people who represent us, whether you voted for them or not, they represent us as your or my congresspeople, senators, as the president. Listen, reach out to the White House, reach out to your congressperson, reach out to your senator, remind them of President Trump's campaign pledge, and try to actually build real public pressure around that specific point, because I think it is tangible, and it is, I think, an area where I would hope Republicans and Democrats alike in Congress would be responsive to constituent pressure.
Mm-hmm.
I think that's an excellent point. But I think that people feel afraid, like this is too big of an issue for them to make an impact as one individual living in, a rural area or even an urban area, to write a letter, dear President Trump, you said that you were going to do X, Y, and Z. I'm not seeing it happen. When can I expect real enactment? Yeah. But so at the local level, Chelsea, what do you suggest that people do? How do they do this if they want to inquire or advocate for IVF coverage?
Well, I do think I think every elected official is not invulnerable to mass amounts of kind of public pressure. So I would urge people, if this is something that is really a centrally kind of motivating cause, mission even, to call your representative, your senator, the White House every day. Like I think that does matter. I also think trying to put it in front of your governor, so your governor could maybe help advocate. I don't think Governor Abbott will, but maybe others might. I think that there's been some kind of early work done around at different state levels. Could state Medicaid provide coverage, for a cycle or 2 or 3 cycles or whatever the right number of IVF treatments would be? I think that also is hugely, vitally important to continue to kind of push and advocate at a state level, harder now because of all the pressures coming from the federal side, against Medicaid, but still, I think, really important. And I was quite struck, Brittney, by what you said around reproductive endocrinologists and there only being 1,500 or so in active practice. I would also say, to anyone listening who has a young person in their life, or even not so young person in their life, who's in medical school and kind of thinking about kind of what areas to specialize in, this clearly is an area where we need more smart, ambitious physician scientists to direct their kind of intelligence and their curiosity toward. And so I think that also is an arena where kind of anyone could potentially make a difference if there's someone in your life who is thinking about going to medical school or in medical school and hasn't chosen kind of in what arena to specialize.
To that point, do you think that the abortion bans will be a deterrent to students in medical school who might be on the fence about subspecializing in reproductive endocrinology?
We already know that the abortion bans have had a chilling effect on medical students in the states where the bans have been enacted, not wanting to go into OBGYN care. And we also see that in some states more than others, to be fair, so this is not, I think, universally true across the abortion ban states, but it's certainly true in some states where it's really having an effect on the ability of some hospitals to fill their residence slots in OBGYN care, partly because students have to leave the state for their required training in abortion care, right? So they're not able to access that in the residency programs, in the states, with the strict ban. So I think really it requires a lot of logistical choreography for the residents in those states. And some, and I've spoken to some of them, are very committed. They want to serve, in their home states or in the states they feel these deep connections to, and they have a high tolerance for that logistical kind of choreography. I don't think, though, that's understandably true of everyone. So it's very worrying that in the places and spaces where we need doctors the most, we may have the fewest.
Yeah. It's just so mind-boggling, right, to think that these schools won't and can't include this part of the curriculum, right? You two were talking about where your kids go to school earlier. You would never send your kids to a school knowing that they're getting an incomplete education, that a big piece is missing. It just doesn't make any sense.
But Amanda, you and I have talked about this. Like I went to public school in Arkansas, like in the 80s and the early 90s, and I had age-appropriate reproductive and sexual health education, and that would not be true today.
No.
And that's deeply painful and upsetting to me.
Yeah, and talk to us a little bit about what are the ripple effects of that.
Well, the ripple effects are manyfold. I mean, one, we know that young people are, of course, like still going to have questions, and so oftentimes, we hope that they're asking their pediatricians or trusted adults. We know that many of them are going onto social media and onto TikTok and having questions answered on social media and TikTok instead of a trained teacher. Who, again, 30 years ago would have taught us in that.
And who knows if the answers they're finding are
who knows
accurate.
if the answers they're finding are accurate, are real, or evidence-based, or like with a real pedagogy behind them. Probably not. We also know that many kids, and I find this like viscerally like so upsetting and worrying as a parent, like many kids like find their way to pornography and then use pornography to help quote unquote help answer questions about kind of sex broadly. We know that many we know that in I shouldn't say many, at least in some school districts, when kids have gone to like local libraries to try to look up information. Sometimes librarians are worried about even giving like the American Girl doll book on puberty. I mean, things that are not, I think, terribly controversial and that actually have real like evidence, based kind of lessons in them. Giving that to kids. So I just think it's kids are going in many different places, and we hope that they're not going to TikTok or to pornography or just listening to like their friends' older siblings, but hopefully they are going to their pediatrician, they're going to their parents, going to trusted teachers or librarians, and getting, again, age appropriate, always age appropriate, but real answers and not the opposite.
Yeah, man, as a parent, it must be so scary.
My children have no access to social media or devices, and thankfully here in New York, in New York State, we still have evidence-based, age-appropriate, even just information for kids about like their bodies broadly, having nothing to do with the rest of our conversation. Yeah. So,
well, one thing I wanted to ask you about is I was really surprised when I started my fertility journey that reproductive endocrinology is vastly, by and large, unregulated. What do you think that tells us about how we as a society value women's fertility?
Well, Amanda, it wasn't until the early 1990s that women were even like required to be included in clinical trials. And it wasn't until like the early 2000s that children were required to be included in pediatric trials, right? So that also is kind of a sobering moment for parents, for all of us to realize, like, we give our children all sorts of things that were tested on adults, where we know that kids are not many adults. Like a child's biology is quite different than that of an adult. It's not like, my 6-year-old is just like 25% of me. No, that's just not.
She's not using your retinol.
Like we're not.
The term mini-me isn't quite appropriate.
Not remotely how life works. So I start there in answering your question because I think that for longer than not, we have not adequately invested in women's health and well-being, like from a research dollars perspective. And of course, that also has gotten harder in the last months in this new administration, given all of the rollbacks to NIH grant funding, including many that have related to women's health and well-being. We have not had commensurate investment in kind of the private markets into kind of women's health and well-being, and our regulatory architecture has to be fair to, I think, different administrations, Democrat and Republican alike. They have tried to catch up. I think kind of the FDA in terms of kind of remit and kind of the experts there to be able to kind of better assess more and more kind of therapies, treatments, screening devices, et cetera, as it relates to women's health and well-being, both specifically for women and then, different things in medicine that are being proposed for women and men alike. That being said, I am concerned in this moment where we have a Health and Human Services Secretary who is actively rolling back the ability of many different parts of our public health infrastructure, including the FDA, to be able to adequately assess and evaluate many different proposed either diagnostic or treatments for women, men, and kids alike. That the answer to your question is it's only going to get harder. And I'm also concerned given what we've seen happen as it relates to RFK Jr. overruling even his own expert panel on kind of vaccine recommendations, on possibly delaying forever, the Preventive Services Task Force ability to kind of meet and make recommendations, potentially including at some point around kind of fertility screening, that it just is harder and harder to have a system that really could and absolutely should work better for women.
Yeah. Gosh. Well, there's on the other hand, to try to, have a little bit of hope here, it's been encouraging to me to see so many female investors who are investing in this exact issue, whether they're donating in the legal services or the research or the technology. There does seem to be a big push maybe in the private sector to try to figure some of this out. But yeah, it's very, very scary.
Yeah. So on a more hopeful note, Chelsea, is there anything in particular that makes you optimistic about the future of reproductive health?
Well, I'm a fundamentally optimistic person because I just don't want to be a cynical one. I think it would be an unhealthy place for me to reside emotionally. I also think that cynicism is kind of the great resource of the people who want to protect the status quo or who want to kind of retrench back into kind of other eras of history that were not as kind of good for women, to put it mildly. So constitutionally, I'm a more optimistic person than not. And also, I would say that I'm incredibly optimistic, partly because there's so many people who are working so hard in this area specifically, right? There, Amanda, you mentioned earlier, all the people who are investing time and energy, right? The lawyers who are pushing back against all the bans, the doctors that are every day trying to figure out how to care for patients, the advocates that are trying to expand access to kind of insurance benefits, access to care, the educators who are still trying to ensure that people of any age, young or not so young, have real evidence-based information about healthcare broadly so that they're able then to help equip people with the ability to ask better questions, the efforts to destigmatize anything and everything that we've talked about so that more women and the men who support us can join these conversations. So all of that makes me optimistic that in a moment where there's so much kind of pushback against women, period, I would say, women's agency, women's rights, there are a lot of women, and thankfully some men, who just refuse to accept that and are still trying to push forward.
Mm-hmm. It's so true. There's so many passionate people who are fighting so hard every day. So yourself included.
Well, trying.
Well, we want to be respectful of your time, but thank you
Amanda and Brittney,
so
thank you
much
for
for
having me.
coming.
Thank
This has been
you.
amazing.
Thank you so much.
Very grateful.
Thank you.
Yes,
Anytime.
thank you so much.